So basically, what I've been working on mostly is a specific subtype of acute myeloid leukemia, the so-called FLT3 mutated leukemias. So FLT3 is a very recurrent mutation in acute myeloid leukemia and is unfortunately one associated with a poor prognosis for patients. So acute myeloid leukemia, unfortunately, it is itself a very aggressive disease, and the outcome, generally speaking, for patients is still not satisfactory. But FLT3 mutated AML are particularly a particularly bad prognostic group. And we do now have some novel therapies towards this type of leukemia. We have specific inhibitors that target this abnormal protein, this FLT3 protein, which is a receptor tyrosine kinase, which can be inhibited by a small molecule. But I have to say, and I think it's commonly agreed in the community, that despite the fact that we've known about this mutation for a long time, the reality is that these targeted therapies are not as effective clinically as we would have hoped. And this raises the question as to why this happens, and is there any resistance mechanism? Is there anything that we can do to try to understand why these therapies have not fulfilled their promise to a certain extent? And I think my personal interest then has been looking at what happens to the metabolic rewiring within the cells when they are treated with this inhibitor for FLT3. So I've done some preliminary work where I basically looked at what happens to the metabolism of FLT3 cells before they get treated with a specific inhibitor. And then I went on to look at what happens once we inhibit the FLT3 protein with this specific molecule and see whether there's changes in the metabolism, which cells use to adapt to the therapy and somehow overcome the deleterious effect that the therapy should have. So establishing a resistance mechanism effectively. And by looking at the changes in the metabolism, then we could potentially identify other therapeutic vulnerabilities which we can use in combination with the FLT3 therapy in order to improve our ability to eradicate these cells. And effectively what I've been able to show so far has been that FLT3 cells use a lot of glucose, sugar effectively, to fuel their metabolism. But this process is impaired, is reduced once they're treated with the FLT3 inhibitor. And at that point, their metabolism switches and they start to utilize more another nutrients, glutamine, which is one of the most abundant amino acids in our body and one of those that we can easily find through our nutrients as well. And as a result of that, glutamine metabolism becomes a potential therapeutic vulnerability when it's targeted in combination with FLT3 inhibition. And luckily, we now have a renewed interest in cancer metabolism, and over the last few, at least 5 to 10 years, there's been an enormous amount of information gathered about the role of metabolism in cancer. And luckily, there's been also development of new novel small molecule inhibitors of metabolic pathways. And we do have inhibitors of glutamine metabolism available with us. And that means that we can actually use them in combination with FLT3 inhibitors. And that's exactly what I did in my preclinical work, which I presented yesterday, is to show that when you combine FLT3 inhibitor with glutamine metabolism inhibitor, the combination of two is able to synergize and kill the leukemic cells more effectively. It is obviously at the moment a preclinical information, and I'm still trying to work out exactly all the mechanisms behind that, because obviously what glutamine does in order to support cell survival is still not entirely clear. I have shown some possible explanation for that, about the role of glutamine in redox metabolism within the cells, about the role of glutamine in supporting the respiratory function of the cells. Above all, I think the most important thing for us is to try to validate these in different models. So using both human cell lines, using primary sample from patient and animal models in order to have significant preclinical evidence that this combination treatment might be actually beneficial for patients. And once we have gathered all this information, and I'm hoping to be able to do so in the next few months and potentially within a few years be able to, me and other people who are working on this, publish and demonstrate this is actually possible, then I think the next step will be to take this on to the patients, obviously.